Antipsychotics has a risk evaluation mitigation strategies program, so REMS program. And out of the choices were clozapine, risperidone, aripiprazole, and haloperidol. The only one is clozapine. So clozapine has one, and we'll talk a little bit about another one that has one as well later on in class. True or false, antipsychotics can be given via intramuscular injection for acute psychotic agitation. That is true. Which of the following is a positive symptom of schizophrenia? The options were muscle stiffness. That's not correct. Hallucinations is correct. So we'll talk a little bit about positive symptoms, which are things that are present, symptoms that are present that should not be there in the quote-unquote normal person. So normal, of course, can be variable by definition, but in the majority of people, hallucinations should not be present. Flat affect is actually a negative symptom, and then happiness has nothing to do with schizophrenia. True or false, patients diagnosed with schizophrenia should only receive antipsychotic treatment during acute episodes and not chronically. That statement is false. So there is no cure for schizophrenia, so if somebody is truly diagnosed with it, then they should be treated lifelong. Number 5 was, how are antipsychotics thought to work in schizophrenia? And the answer would be dopamine antagonism. So they are thought to work by blocking dopamine in the brain, and that's what all antipsychotics do. Number 6, which of the following antipsychotics must be taken with food? Out of all the choices there, quetiapine, doesn't matter. Lorazepam has to be taken with a meal of at least 350 calories. Haloperidol, doesn't matter what you do, eat or not eat. Same thing with chlorpromazine, doesn't matter. Number 7 was, which of the following metabolic parameters should be monitored in patients receiving olanzapine? And this is basically for all antipsychotics, but it was all of them that were listed. So weight, waist circumference, blood pressure, blood glucose. The other things that you would monitor are lipids. And then at baseline, you get family history. Number 8 was, what medication should be given to treat patients who are experiencing antipsychotic-induced dystonic reactions? And out of all those choices, benztropine is the only anticholinergic agent. The other options were alprazolam, that's not correct. Dantrolene, not correct. And morphine, definitely not correct. Number 9 was, which of the following antipsychotics comes in a long-acting injectable formulation? And out of the available options, so we have haloperidol, that is correct. That's the correct answer. It does come in long-acting. Brexpiprazole does not. Cariprazine does not, and neither does ziprasidone. The last question was, true or false, the overall goal of treating patients with schizophrenia is to obtain baseline functioning and to improve the quality of life, which is true. So we always target some of the symptoms in different phases of treatment, but the overall goal for treating somebody, if you want to get rid of their hallucinations, the reason you get rid of hallucinations is to try to get them to function again, so they can live their lives. If you get rid of the hallucinations and they're still not able to function, then there are other things that you need to work on as well. So it's not just targeting just a handful of symptoms. You're trying to treat the entire illness. All right, so because my computer screen is not working, I have uploaded the grid for today of all the groups that are going. And the way that I usually do class is to go through the cases, and I ask one team to answer the question, and a second team for an alternative answer just to follow up on their thoughts. If you have different answers or comments, questions, and you're not part of whatever is listed here, just feel free to chime in. So I accept all questions and comments, okay? So it's under ELC right now. So let's get started with the cases. Hopefully a chance to review everything. So the first case has to do with the patient AH, who is a 53-year-old male admitted to the emergency department with a couple of different symptoms. And let's go with question number 1. What symptoms of schizophrenia does this patient exhibit, and what type of symptoms, positive, negative, or cognitive, would each be classified as? This will go to group 1.
He has some positive symptoms such as paranoia and delusions.
Okay. Anything else?
He has a history of schizophrenia. He's been experiencing agitations and some bizarre behavior. He also has poor personal hygiene, noticeable body odor. He has some disorganized speech, and he has paranoid and persecutory delusions, which are positive. He doesn't have many negative symptoms.
Okay, good. Group number 25. Any additional symptoms or anything that you disagree with from group 1?
We agree with group 1.
Okay. Anybody else have any other comments? So I would say that, yes, the positive symptoms are disorganized behavior as evidenced by pulling down his pants, wearing multiple towels, eating out of the trash can, having bizarre behavior, having paranoia, disorganized speech, delusions. Negative symptoms are things that are not present that should be there. So in most people have motivation, they have interest, they have a full range of expression. So a flat affect is when somebody is talking about something that maybe excites them or makes them happy, but you can't tell because their facial expression is two-dimensional. It's very flat or blunted. So in terms of negative, he may have a motivation because he's just not really taking care of himself with poor personal hygiene and body odor and that type of thing. He may also be withdrawn. And then with cognitive symptoms, his memory is noted to be fair, but it's not really clear what are the cognitive symptoms. And sometimes, well, he could essentially have poor executive functioning. So executive functioning would have to do with things like getting dressed in the morning. It would have to do with maybe cooking a meal. So you got to cook a meal in a certain order, you might burn down the kitchen. And then I think in the slides I put balancing a checkbox. I'm not really sure who does that anymore, but it's just things that take a stepwise process. And you have to do things in an orderly process to get to the end result. So the reason I kind of break these down into symptoms like this is because positive symptoms are more likely to respond to medication treatment, and negative symptoms and cognitive symptoms are not really responsive. Any comments?
Dr. Van,
Yes.
on your slides for cognitive symptoms, you said working memory. That mean like a good memory? I'm sorry, I just misunderstood that.
Yeah, sure. So working memory has to do with being able to pull things out of your memory when you need them. So for example, when you're doing this case, you should be able to pull memory from your preparation for this case. For example, you watch the videos, you read the materials, and you pull out information. So working memory is while you're doing a certain task, you have certain things that you need to remember in order to do that task. So for example, another example is when you take a test, good working memory is if you are able to recall what you learned in the past in order to complete the test. So does that make sense in terms of working memory?
So do we consider a cognitive symptom it's a bad working memory? Because you just put working memory on your slide.
Okay, sorry, yeah. So poor working memory would be the cognitive symptoms. Yep, thanks for clarifying that. So poor executive functioning, poor working memory. Memory can be long-term, short-term. It can be retrograde, anterograde, that type of stuff. Just inability to concentrate and poor attention, so all those types of things. And some of these things can overlap, but just know that negative cognitive symptoms are just harder to treat than things that are like hallucinations, delusions, and paranoia, and disorganization. All right, so good question. What are the goals of therapy for this patient? Number 2, group number 18.
In the short term, right now we want to stabilize or reduce his acute symptoms, so all the kind of agitation, hostility, and bizarre behaviors that he's displaying, since most of those are positive symptoms, we could probably control those with his medicine in the short term. So in the first week, we want to stabilize him with acute therapy and then move into stabilization and maintenance therapy to get him back to his baseline and improve his quality of life.
Okay, great. Thank you, group 18. What about group number 10? Any additional goals?
We also want to introduce some social aspects for his therapy as well.
Okay, and I would do that in the stabilization and maintenance phase, possibly. Yes, that's very good. Yep. So later on, so the acute therapy is whatever is usually landing the patient in the hospital or what's causing disturbances. So if you see maybe somebody out on the street causing a scene, having hallucinations, eating out of the garbage can, screaming at people. Those are the symptoms that you kind of want to treat first because that's what lands people in either jail or the hospital. And then once you've stabilized those symptoms, people can be discharged, and then you start working on things like psychosocial interventions, socialization, all those things that help people integrate back into society. So the other thing I would want to point out is some of the goals are just to make sure the patient can tolerate their medication, so just check on side effects, and then also to encourage adherence. But with stabilization, you want to achieve remission, and then with maintenance therapy, and keep the patient in remission, so you don't want relapse. And then with maintenance therapy, you want to prevent recurrence, rehospitalization, and relapse. So this might be a little bit confusing, but when you think about mental illness, generally we think of things like exacerbations. So every exacerbation is kind of like an episode. So somebody has schizophrenia, it's a chronic illness, and then when they get sick like this, they come into the hospital. So it's like, if you're thinking about a COPD exacerbation, that's sometimes what brings them into the hospital. And so when you're thinking about stabilization treatment, you're trying to prevent the patient from going back into that same exacerbation. So that's considered relapse, okay? So you're trying to prevent the patient from getting sick again during stabilization therapy. Maintenance therapy is to try to prevent future exacerbations. So it's kind of preventative therapy so that the patient doesn't have acute psychosis in the future, because every time a patient becomes very psychotic, it's very stressful to the brain, and the thought is that there are some minute amounts of brain damage that occur over time that cause the patient to reduce their baseline functioning. So if somebody's had schizophrenia for 25 years and they've been non-adherent, their baseline function is going to be pretty low, as opposed to somebody who's newly diagnosed with schizophrenia. So those are just some things to help distinguish between stabilization and maintenance therapy. But overall, making sure the patient tries to get back to their improved quality of life and baseline functioning as best as you can. All right, so let's talk about some of the different treatments. Please evaluate the appropriateness of each of the following antipsychotics. Group number 2, and I'm actually just going to ask you to pick a couple of them and let me know, and then we can just talk about it as a class. So group 2, you can just pick what you want or tell us about all of them. It's up to you.
Okay, so we would pick for the short-term treatment aripiprazole 5 milligram injection every day for the immediate action, and for that we monitor. Oh,
But yeah, I'll accept your answer. But if you have any other thoughts about any of the other agents, let me know why you chose specifically aripiprazole and not something else.
Alright, so we chose aripiprazole because it has minimal effects on prolactin levels, and since he was stating how he didn't want the paliperidone injections because he was, quote, turning into a woman, he may have been suffering from hyperprolactinemia, so aripiprazole doesn't cause as much of that.
Okay, awesome. Let's see, group 26. Why did you not choose some of these agents? Or what would you consider possibly an option? We will eventually go through all of them.
So we thought clozapine might be a good option. It's the next step down in the algorithm. And it does cause quite a bit of orthostasis, but not as much on the prolactinemia.
Okay.
And it's a very, very strong medication, so it'd be good for this patient.
Okay. Awesome. Okay. And I'm going to gather up thoughts from any other group. So let's kind of go down through the list. Let's talk about first generations. Are they a good option or not a good option? Anybody have any thoughts?
Okay. We said no to the first generation antipsychotics because they can cause gynecomastia, and this is already causing him extreme distress.
Okay, great. Yeah, so I would go ahead. If there's somebody else want to comment?
Haldol works wonders, and I think
I think that, just for an acute episode, one injection of Haldol is not going to give this guy gynecomastia. So if you want to calm him down, then transition him to maintenance therapy on a second generation antipsychotic that is less prone to developing, gynecomastia. That might also be an option.
Okay, I think that is a solid treatment plan. My usual recommendation is to think about what the patient is going to be on long term and try to start them off on something like that now, because if you use something acutely to control the symptoms, you're going to have to get up to speed later on with titrating, switching the patient to something else, which could be at risk for decompensation. So most providers, what they will do is think about what should this patient be on, and are there short-term availabilities, is there a long-acting injection available, and then they would potentially do that. But your strategy actually makes sense as well, but I wouldn't ask, just for exam, I know students like to ask about exams, but I wouldn't ask, I wouldn't give you that option on the exam, because we would like to try to select something now that we would keep the patient on long term. But in clinical practice, we do that. So with the first generations, feel free to jump in if anybody else has any comments. For the first generation agents, they do have a higher risk of hyperprolactinemia because they're such potent dopamine blockers. The other thing that I was thinking about for this patient is adherence, because he has issues with adherence, just forgetting to take his medications. And so out of the first generations, there's only a couple of them that actually have a long-acting injection. So we'll just say, put that on the back burner for now and check out to see if the second generation agents have anything that's a better fit for the patient. So moving on to the second generation agents. We'll skip out aripiprazole because we already talked about that. Why is lisinopril a good option or not a good option for this patient?
He's non-adherent and there's no long-acting injection for it?
Absolutely. Okay, very good. So no long-acting injection, and he may not be a good candidate because he's just eating and drinking out of the garbage can. We have no control over what he's doing and when he's doing it with the food. So he may not be a candidate for sublingual administration. So not really an option at this point. What about piprazole? Any thoughts on brexpiprazole or cariprazine? So they have similar issues.
Cariprazine mostly does negative symptoms and he has a bunch of positive symptoms.
Okay. Yeah, so cariprazine is a little bit better for negative symptoms. Brexpiprazole is very similar to aripiprazole, but neither of these medications has a long-acting injection. So I'm thinking about the future for this patient. He probably needs to be put on a long-acting injection because his non-adherence is, it may land him back in the hospital, but he also is having some side effects. Clozapine we'll talk about in a little bit, but I like your points for that. Iloperidone, again, no long-acting injection. Lorazepam, any thoughts besides no long-acting?
It seems like he's eating a little irregularly, so he might not be able to be trusted to take the pill with a meal.
Absolutely. Okay, so the absorption of the medication is affected if it's not eaten with a meal of at least 350 calories. So you don't want to reduce the efficacy, or you don't want to put the patient at risk for decompensation just because he's not taking his medication correctly. So olanzapine does have a long-acting injection. So why may it not be an option for this patient?
It has a high chance of orthostasis, and he's had that in the past with other medications.
Okay, orthostasis. There's one other thing that actually applies to patients that may be receiving this medication in general that kind of make it just not a great option. So what's the problem with olanzapine long-acting?
metabolic disturbances.
Okay, that's true.
There's no REMS.
Yes. Okay, so that's what I'm looking for. So, does he have metabolic syndrome? I don't actually think that he's diagnosed with any other disease states other than gynecomastia right now. So yes, we are concerned about metabolic syndrome, but in terms of the REMS program, this is a general thing that prevents us actually from putting a lot of patients on the medication. So the REMS program is there because of post-injection delirium sedation syndrome, and that has led to reports of death. We're not really sure if it's positive, but it can land people in the ICU because they require intubation. And every single time a patient gets an injection, they have to be monitored for 3 hours and they cannot drive home afterwards. So just because the administration is a little bit difficult, we don't routinely use that unless there's a good kind of infrastructure in place for the patient to receive the medication, meaning that they're basically institutionalized in a long-term chronic hospital for years. Otherwise, a patient will not sit just so that somebody can babysit them for 3 hours while they make sure that they don't get PDSS. So overall, that long-acting injection is like the bottom of the list in terms of what we would recommend for patients, just because it has so many issues.
Dr. Fan,
Yes.
does olanzapine, is it just the long-acting injection that has the REMS program, or does the oral one, does the capsule have it?
Yeah, so it's only the long-acting injectable that has it. So olanzapine actually comes in an intramuscular rapid-acting for acute agitation, and it does come oral, like you mentioned, an orally disintegrating tablet. So the reason why we think that the long-acting causes the sedation syndrome and delirium syndrome is because we think that people are mistakenly injecting the medication into a vein or artery, and it's getting into the system and causing spikes in that medication. So the REMS program is only for the long-acting injection because it's such a high dose of medication. If it accidentally gets intravenously, then that would lead to the PDSS. So there is no concern with that syndrome or any of the other olanzapine products.
Thank you.
Sure. Good question. What's wrong with paliperidone?
The patient had gynecomastia with it before.
Okay. Right. Okay. Was he on paliperidone or was he? Yes, he was. Okay. Yeah. So, what is the relationship between paliperidone and risperidone?
Paliperidone is a derivative.
Yeah. Okay. So it's the active metabolite of risperidone. So whatever happens with risperidone is going to happen with paliperidone. Whatever happened with paliperidone for a patient is going to happen with risperidone. So they're very similar medications in my mind. So and in this patient, obviously, he had gynecomastia from either both of them or either of them. But it's very highly dopaminergic, anti-dopaminergic. Quetiapine, we talked about no long-acting injection is available. And for the most part, when you use quetiapine in somebody with psychosis, you need to get to higher doses, like 600 to 800 milligrams, because it's kind of a light antipsychotic, which can lead to a lot of drowsiness and sedation. Risperidone is not a good choice because of the gynecomastia, and the patient also doesn't want it anymore. The same thing with the paliperidone. And then ziprasidone. Any comments on that?
There's no long-acting injectable for it?
Yep. And then meal stimulations. But it does have a short-acting injection that you can use for acute agitation. So there's a minor plus. So now that we've gone through all of them, and we've kind of put aripiprazole and clozapine to the forefront, I want to hear what group number 19 has recommended and group number 11 before we talk about what would be best for this patient. So number 4, please make a short-term and long-term treatment recommendation. Group number 19.
For short-term, we said use aripiprazole tablets, 10 to 15 milligrams PO once daily for 14 days to assess tolerability and efficacy.
Okay.
And then after that, change to long-term treatment, which is long-acting injectable of aripiprazole, 400 milligrams, and overlap that with the oral tablets for 14 days. And then you're going to give the injection once a month. And then you want to monitor, we chose aripiprazole to increase adherence because the patient didn't prefer a paliperidone injection. And you want to get a baseline, monitor weight, blood pressure, fasting blood glucose, and the lipid panel.
Okay. All right, so we got aripiprazole and a good short, long-term plan. Let's see, group number 11, what do you guys think?
We said the same thing. We're going to start with aripiprazole, 10 milligrams daily, and then titrate up. And if it becomes more adherent later on, we can do the injectable.
Okay, and did you guys decide on how you would transition the patient to the injection by any chance? Bolus or oral overlap?
Oral overlap.
Okay. All right. Anybody do anything different? So we're going to talk about aripiprazole, we're going to talk about clozapine. But I just want to hear if anybody decided anything else was better. Okay. So let's talk about clozapine just briefly, because my choice I wrote down here, I would treat the patient with aripiprazole as well. So I think when you look at the algorithm for treating schizophrenia, the algorithm is, there really is no algorithm that is, the treatment of schizophrenia is antipsychotic. So even though you have first, second, and third level says clozapine, what we really should do is try all the different first and second generations unless we think the patient is a great candidate for clozapine. Now, there are clinics out there across the states that will do first episode clozapine because the thought is the more episodes of psychosis you have, the more likely you are to cause brain damage and lower your functioning. So if you had schizophrenia, would you want to be treated with the most effective medication ever and have to take blood draws every week? Or would you rather work your way up to needing something like clozapine? And I think that answer is going to be a little bit different from everybody. So if it were me, I might just want clozapine because I want to preserve my brain. But other people might not want to deal with blood draws every week and not like that. And so in general practice, we will go through a bunch of different first and second generations antipsychotics as monotherapy before we go to clozapine, unless the patient is willing to be on clozapine. But I think it is the gold standard medication. Out of all antipsychotics, it has been proven to be the best. That is the only one that is consistently proven to be the best. So if you want to put the patient on clozapine, then you just have to monitor them. And then this guy's a little bit non-adherent. So my concern would be if you're off clozapine for like 72 hours, which is, the half-life is about 24 hours. So if you're off the medication for 3 to 5 days, you don't have any medication anymore, you can't just start back on like 300 milligrams a day. You have to re-titrate the patient, and that's going to take a couple of weeks. And so if the patient's not adherent orally, I don't really want to put them on clozapine because it's going to be very difficult to manage their symptoms. You got a question?
So, if a patient's experiencing an episode, is it appropriate to have a talk with them about clozapine, or they can handle taking it?
Yeah, so the question was, I don't know if your microphone's working, because like some of them don't work. The question was, if a patient is psychotic, are they appropriate to have a conversation with? So not every patient who is psychotic doesn't know what's going on. Some people are psychotic and they have symptoms and they're able to function and tell you all these things, and they're just living with all of these different symptoms. So if they can make a decision for, if they have insight into their illness, insight meaning they know they're sick, they know these symptoms are not quote unquote normal, and I use normal kind of a light term because I know, politically it's normal to be anything. But if they have symptoms that lead them to the diagnosis of schizophrenia, you do talk to them and determine how much insight they have into their illness and their judgment. So their judgment is the ability to make a decision about whether or not to take treatment for insight into their illness. If they have poor insight, they don't think they're sick, and that leads them to think that they shouldn't take medications, then, and this is getting kind of not on the test material, this is just what we do in practice. Then you offer the medication to the patient, But if they refuse it and they're not violent to themselves or anybody else, you cannot force the patient to take the medication. Because if you force a patient to take medication, you are taking away their rights and you're basically assaulting them. But if a patient is extremely psychotic and they are like kicking people, they kick the walls down, they're hurting staff, then you can, what we do in the hospitals, we get 2 physicians to determine this patient is not competent to make a decision, and we force the medication on them. But we don't do prolonged forcing the medication. So once they receive a couple of doses of medication, the patients usually calm down and can have a rational conversation, even though sometimes it's still a little bit bizarre. So we do talk to patients to see how good of a historian they are, and if it's not good, then we'll do something very acutely. But if they are good historians, then we kind of try to work with them the best that we can. But it's going to be a little bit different, and that's patient specific. So yes, good question. Talking about just the global aspects of treating mental health patients.
I do have another question.
Yeah, sure.
So for the purposes of the test, can you put a number on how many medications a patient will have had to fail in order to escalate to clozapine, or number of treatments or something like that?
For purposes of the test, I would say there's not an exact number. They would have to fail all the best options, and then the worst, or if the only option left is like thyroxine, which we don't ever put anybody on because of the high risk of QT prolongation, I would go with clozapine. So you have to make the assessment based on the patient. Are there, out of the 4 options left, are any of these better than clozapine? And if none of those are better than clozapine because the patient has adverse reactions or allergies or whatever the case may be, then you choose the clozapine. And I know that that's not going to make very many people happy because it's not a concrete answer, but that's just what we do in clinical practice. Depends on, if there's nothing better than clozapine, then we choose clozapine in terms of, you know, the risk and benefit profile. But I will not ask you to select clozapine as a first or second line treatment. Okay.
Thank you.
Usually it will be at least third line treatment and later, because that gets kind of more kind of expert level type stuff. Not that. So the thing is, you guys probably may see schizophrenia, but you're not going to see a whole bunch of schizophrenia patients. But antipsychotics are used all over the place, not just for people with schizophrenia. So this is an opportunity for you to really get to understand the role of antipsychotics and what their side effects and what their side effect profile is. So just taking it to aripiprazole. So I agree that aripiprazole, I would also say 10 to 15 milligrams per day. And we can start 10 to 15 because there really is no drowsiness situation that happens. So we could just start there to target the agitation, impulsivity, irritability, and try to stabilize the patient as quickly as possible. And then once the patient is stabilized, then I would potentially transition to the long-acting injection, and there are a couple of them. So I will not ask you to know specific doses of medications, because those are things that you can look up. I asked them here just to make the point of titrating or not titrating and that type of thing. So then you would switch over to, it sounds as if most of you selected Abilify Maintena, but I actually might consider Aristada instead, because if he leaves the hospital and he's supposed to take 14 days of medication, he may stop taking it or forget to take it. So with the Aristada, you can take a bolus injection with 1 oral pill and the long-acting injection all in the same day, and you won't have to take oral medication after that. Okay, so if you don't have a bolus, you have oral overlap, because you got to cover the time period. It takes a long time for long-acting injections to actually come out of the muscle and start working in the system, start working in the body. But definitely make sure the patient is tolerating it and responding to it before you switch them onto a long-acting. So if a patient comes in first day, you do not give them a long-acting injectable right away, because you don't even know if the patient is going to have a side effect to it. You don't even know if that medication is going to work for the patient. So establish it on oral therapy and then switch them over. Now, someone brought up a good point about acute treatment. So with the pill, sometimes it takes about 3 days to start working. So if you want to do treatment for acute agitation, what are some of your options? Let's say the patient is, has just thrown a bunch of, pens at the rectal therapist, and they're just causing a scene in group therapy. So what could be offered to the patient? to help them calm down today, right now.
Could you do haloperidol IM?
Yes, okay, so this goes back to what the previous, I'm sorry I didn't get your name, the previous patient said, let's do Haldol IM, and then transition him. So I would actually do Haldol IM PRN for a few days, and then once the patient starts to get stabilized on the aripiprazole, I would discontinue the haloperidol. Aripiprazole does not come in a short-acting antipsychotic injection, so there's no way to get the medication in this patient faster to start working today. So you have to choose something else. So you can choose a rapid-acting Haldol injection, and that will help him currently, especially if he's psychotic. The other options you could potentially choose are Klonopin or clonazepam or lorazepam. So you could give him a benzo if he's like just very, very agitated and anxious. So either of those options could be appropriate. If the patient is just trying to get the nurse, usually we'll give them both the antipsychotics and a rapid-acting benzodiazepine. So, sorry about all the noise. We're having some renovations going on next door. Okay, and then the monitoring parameters. I think Group 19 stated it nicely. You've got metabolic monitoring with weight, waist circumference, blood pressure, blood glucose, lipids. And then you also want to, okay, well, this takes us to the next question. Does anybody have any comments about number 4 or don't understand what I said about any of the medications before we move on to question 5?
Could you briefly repeat what you were saying about the aripiprazole injection versus oral overlap?
Yes. So aripiprazole comes in 2 different types of long-acting injections. Okay, and that just has to do with the way that it's delivered. One is called Abilify Maintena, which I think is what some of you guys who chose 400 milligrams. That's the Abilify Maintena. With that, you have to do oral overlap for 14 days in order for the long-acting to start working. That's one type of injection. There's another type of injection called Aristada. So Aristada is also comes in a bolus injection, but the bolus injection doesn't work on the first day. So in order to get a patient initiated on that long-acting injection, you would do Aristada Initio, and 1 oral dose of Abilify, usually 30 milligrams. And if you don't do the bolus injection, it's like 675 milligrams. If you don't do that, you have to do oral overlap for 21 days. So,
But you were saying you would choose that for this patient due to the concern for adherence?
Yeah, the reason, I would choose that for this patient, just to cut out him having to take oral medication for, 2 to 3 weeks. And he doesn't really complain about taking shots, so you do have to give 2 shots, and usually you give him 1 in opposite arms or whatever the case may be. You don't give them both in the same arm. But all those options, are solid plans. I just prefer to reduce the amount of oral medication the patient receives. Okay, question number 5, let's talk about education for the patient. Group number 3.
So we just want to discuss the possible side effects that he could experience, and maybe some restlessness, agitation, and then to let him know that if he experiences any of those, we could consider managing them or switching to an alternative agent, and then just to inform him that it may take a little while to see the effects of medications, and if he experiences any rigidity, excessive sweating, feeling dizzy or confused, to let us know. And just that it would be required for him to come in every month for monitoring, and just that's when he'll get his injections anyway. And then also just to counsel him on his cannabis use since he tested positive for that and how it can interact with his medication's efficacy and could be causing some symptoms.
Okay.
Also, we would be mindful to use patient-friendly language based on the patient's level of comprehension and health literacy.
Cool. Yeah, that's like a bonus. So a lot of these patients have barriers to understanding or just things that you kind of have to account for when you're educating them. So let's see, group number 7. Let's see if you have anything else to add.
You can notify the physician if new symptoms occur.
Okay. All right. Anything else from any groups? So we talked about efficacy, safety, and avoiding drug use, cannabis.
Tell them the importance of medication adherence and make sure they understand it.
Yes. Okay, so I always talk about that with patients. So, and sometimes it takes a couple of days to actually, until they start, wanting to even consider adherence to the medication. But yes, you want to talk about efficacy, telling patients what to expect, what symptoms will improve, how long it will take to improve, safety, everything was already mentioned. The gynecomastia, since the medications have been changed now, it should probably go away. And he's been off of the medication for some time, so definitely he shouldn't have any of those issues with the aripiprazole. Adherence, the importance of staying adherent so he can stay out of the hospital and keep doing well, and then avoiding cannabis. And so when I talk to patients about drug use, like smoking and things like that, obviously you have to assess if they're ready to stop, and then if they're not ready to stop, it's hard to move forward with the conversation. But with cannabis, as far as we know, there is not a direct pharmacokinetic drug interaction with the antipsychotics in cannabis. And there are actually a lot of patients who have schizophrenia also will use cannabis, and so they're actually looking at drug targets for cannabidiol receptors. But what I usually tell patients is when you smoke marijuana or do marijuana, there's a potential for your symptoms to worsen and for you to stop taking your medications because your symptoms are worsening. And so it's more of a pharmacodynamic interaction than a pharmacokinetic interaction. It's not a direct, again, it's not a direct drug-drug interaction, but their symptoms are going to get worse while the medications are trying to help them, so it doesn't really help them in the end. Okay, any questions about that case? All right. Okay, so let's move through case number 2, and then maybe I'll give you guys a 5-minute break in between. So case number 2 has to do with BB, who is 36-year-old female. I do want to say that all these cases are taken from patients that are on the unit. I did modify some stuff because sometimes there's additional information that you guys don't need to know, but I did not just make up these cases completely, just FYI, in case somebody has a question. So case number 2, question number 1. What positive, negative, and cognitive symptoms does the patient exhibit? Group number 4.
We said that the patient has positive symptoms of auditory and visual hallucinations, cognitive symptoms of poor judgment and insight, impulsive behavior, which is a negative symptom, and family history of schizophrenia, and she's making poor eye contact, which is also a negative symptom.
Okay, great. Group number 12. Sometimes impulsivity can actually be considered a positive symptom as well. So it doesn't really fit very well with any of these things, but I'll take that. Group number 12.
I think they had all the stuff we put down for it as well.
Okay. All right, so, yeah. So auditory hallucinations, she's hearing voices. Visual hallucinations, seeing dead family members flying. And then paranoia, she's eating packaged snacks because she's afraid of being poisoned. So, and the negative symptoms, blunted affect, constraint, cognitive memory is fair, but poverty of thought content. So what that means is there's just not really a whole lot going on when you try to talk to the patient. They're not really thinking very clearly, or they may not be thinking at all. So when you ask them questions, you may get very few responses or few thoughtful responses. All right, which symptoms should be targeted during the acute versus maintenance phase? Group number 20.
During the acute phase, reduce agitation, combativeness, and hostility, and her hallucinations, delusions, paranoia. During the maintenance phase, prevent relapse of symptoms.
Okay. Is she hostile? I don't think she.
No, I think we. No,
Okay, I'm looking up the case again. Okay, she's impulsive, but this patient actually wasn't when I spoke to her. She's very pleasant. She's just very impulsive and very distressed about her hallucination. So she's a little bit different from the other patients with schizophrenia. You will see that they're all different types of how people present with schizophrenia. Some are very pleasant, some are kind of a little bit scary in terms of their symptoms, but this patient's less agitated and aggressive than the other patient. Let's see, group number, was that group number 4? I think that was group number 20. Number 4, what symptoms should be targeted? Do you agree or anything to add?
We pretty much agree with that.
Okay, yeah. All right, so acute phase, yep. Whatever brought the patient to the hospital. Maintenance phase, you're trying to get the patient to keep in remission and prevent relapse and recurrence. Good. So let's talk about your assessment of her pharmacotherapy regimen based on her case. Group number 5, what do you guys think?
So the biggest thing that we noticed at first was that she was started on haloperidol, the long-acting injection, but she was on ziprasidone as her oral medication. So we would want to make sure that she was stable on that oral medication before starting the same long-acting. So we didn't think that they should have started the haloperidol if she was taking ziprasidone, and then. Aside from that issue, the ziprasidone, we would want to make sure that she was adherent and taking it correctly, since it did have to be taken with food. And it does have a risk of a prolonged QTC. But those are the couple of things that we noticed.
Okay, awesome. All right, group number, 13. What else did you notice about her regimen?
We were thinking maybe because she's tried multiple agents and hasn't really had success, that clozapine might be a good agent.
Must be an option, okay. I like your thought. We can talk a little bit about that, what makes her a candidate or not, depending on the answers to number 4. There's a couple of other things too that I noticed. So what was mentioned was she may not have gotten a fully effective dose of ziprasidone. She maybe wasn't eating, so it wasn't as effective even at the max dose. And then they didn't stabilize her on oral Haldol before they transitioned her. There are a couple of other things. What else is there? Somebody speak to being on 2 antipsychotics.
Isn't it that monotherapy is better and there's not a whole lot of evidence for adding multiple antipsychotics?
Right. Okay, so she is on antipsychotic polypharmacy, which is not indicated, okay? So she should not be on both of those things. So we should think about an alternative treatment that has monotherapy. And then the other thing is that she does not want to take a shot. So that should influence your treatment plan for later on, okay? So 4 things: not getting the full dose of ziprasidone, on Haldol without prior stabilization, does not want Haldol or a shot. Actually, she doesn't want a shot. And then she is on antipsychotic polypharmacy. Okay, so now that you're thinking about her current regimen, what's going to help you choose a different regimen? So what factors do you consider when selecting pharmacotherapy? So I'd like a list of individual factors, or maybe not individual factors. Group number 21.
Well, we consider the risk versus benefit of all medications. Some of the risks include hyperprolactinemia, extrapyramidal symptoms, and tardive dyskinesia. But most specifically, we consider the risk of medication-induced weight gain and restlessness, as she has a history of it. We also considered the route of administration because she doesn't want an injection, so tablet solutions and ODT tablets appear to be the best, of course.
All right, so I got side effect profile, and I have patient preference. And I guess we go back to group number 5. So what else is there?
We would also want to consider her meal regularities. Is she eating on normal times? Her past medication use, so what she used in the past and how they affected her, and her adherence ability. Is she able to take a pill daily? And then also her current metabolic state.
Yes. Okay. Awesome. The only other things I had to that list, so what was discussed is patient preference for medications, patient medication history, side effect profile, current medication adherence, which based on her ability to take her seizure medication, it looks like she has good adherence, and she doesn't want a shot. Potential drug interactions, and that's just more of a global thing, not really specific to this patient. Comorbidities, so elevated A1C, she has seizure disorder, and she has obesity. Her eating habits, I would also say her current symptoms. So sometimes when people are not sleeping or oversleeping, sometimes that helps guide therapy, and that has to do with the side effect profile of the medication. Sometimes we take advantage of the side effects of the medication to help the patient in the acute phase. I would also think about home or psychosocial situation. Who can help her at home with medications, or where is she going? Can somebody help her to remember to take them? And then her illicit substance use or alcohol use. So she doesn't use any illicit substances, but she uses alcohol occasionally. All right, all those things are important. So then how would you optimize this patient's plan, or this patient's medication regimen? Group number 6.
We definitely want to discontinue the IM haloperidol because it distresses the patient.
Okay.
But for drug to pick, we kind of need some answers to those questions, like the ziprasidone, if she wasn't eating it with a meal, we could just, if there's a person at home to help her do that, then we could just keep that. If she's tried so many things and wants to try clozapine, we could do that. I guess it just depends.
All right, let's see if group number 14, are you in agreement, or do you have a specific regimen?
Well, personally, I think we really like the idea of Clozaril as well. However, we do know that there is a black box warning for patients with a history of seizures, which she does have. It seems like she's maintained on Keppra, and I don't think it made mention of when she last had a seizure, but I know it's not an absolute contraindication, so she may still be a potential candidate, but don't know about other options because Clozaril seems like, if it weren't for the seizures, would be our best option.
Okay. That is a very solid answer. She also has obesity and elevated A1C, so there's a couple of other things too. I would say that since her seizures are controlled, like you said, it is a relative contraindication. It's never an absolute contraindication unless the patient has uncontrolled seizures. But I did not choose clozapine but it wouldn't be wrong as long as you monitor it correctly. I ended up choosing something else. So I'd like to hear if anybody chose anything else besides clozapine. So for those of you who chose clozapine, your answer is not absolutely incorrect, but you need to monitor it correctly. It would be incorrect if you put the patient on it and then just like didn't monitor them. So anybody choose something else? Also agree with taking the patient off iron Haldol.
We switched her to haloperidol 5 milligrams twice a day.
Okay. Anybody else? Okay, so that's what I did. I did Haldol 5 milligrams to start with, and then we'll see how she does on that medication. And the reason that I chose haloperidol over clozapine is because clozapine had all these other side effects, and then it had metabolic issues, and she is at risk for having cardiovascular disease later on with all these, undiagnosed diabetes and obesity, and the seizure things is not such a concern to me. So I would say haloperidol first and see if she fails that, because we don't know if it's actually working for her. They just put her on haloperidol about a week ago, and you don't actually know if it has started even working yet. So let's DC her current medications, start her on Haldol, and then start titrating up if you need it to help with some of the acute symptoms. The other thing with clozapine is she's having distressing symptoms, and it will take about a week or so to really titrate clozapine up to a very effective dose. Okay? So even though she is adherent, which makes her a great candidate for clozapine, you do weigh the risk and benefits. And at this time, I would suggest haloperidol. But if you were the pharmacist on the unit talking to the patient, you said, hey, you want to do clozapine? And she said, yeah, then you would do it. So some of the other agents, she's had a lot of passive med trials. Does anybody have any questions about why I didn't choose something else? Okay, so the other reason ziprasidone is not really a good choice is because she's already paranoid. So even if you try to tell somebody not to be paranoid who's very paranoid, it doesn't work. It's just like telling somebody to stop believing what they believe, and that doesn't work. And so you have to work with the patient. So if she's not eating because she's paranoid, you really need to switch to something else until she starts to eat a little bit more regularly. And then how would you educate the patient on her treatment? Group number 17. So if you chose clozapine, please let me know how you would monitor the patient. But if you chose haloperidol, please let me know what you chose and how you would monitor the patient, or something else.
How would we educate BB? Clozapine. Clozapine, just do clozapine. Just say we chose clozapine. Or haloperidol. We chose clozapine and we monitor her blood sugar. Yes. Oh wait, we're educating her. Here.
Is group 17 in the building?
Yes, we're here. We chose clozapine, so we would just monitor on medication adherence, and like the elevated or possible metabolic effects, and then the REMS, obviously.
Okay, so what is the REMS? Any other group can help out. Group 8, you can chime in if you have selected a similar treatment or something else.
We also chose clozapine.
And they said to make sure that the patient's adherent, monitor for hypotension, sedation, anticholinergic effects, orthostasis, weight gain, and what was it? The serum level needs to be 250 to 350.
Okay.
And also neutropenia.
Okay. Yeah, so one of the most important things about clozapine is the neutropenia or risk of neutropenia. So what needs to happen for this patient to get put on clozapine? So since a lot of you chose clozapine, I know we have the next patient on clozapine at some point, let's talk about if we're just monitoring for these things right now, and you chose clozapine as your medication, that's wrong because you're not monitoring the patient correctly. So what do you need to do before you put the patient on clozapine?
Check if her ANC is greater than 15,000.
Yes. Okay. Not 15,000.
15,000.
Yeah. Okay. So yes, you have to get a CBC with differential, and that will tell you what the ANC or the absolute neutropenia count of the patient is. And if the patient has an adequate ANC level, then you can start clozapine. At what point do you check the ANC again?
You check it weekly for 6 months.
Yes. Okay. So if the patient is golden in terms of their ANC, then you would check it weekly. If their ANC falls below 1,500, then you're going to do different things. For purposes of the test, I'm not going to ask you, like, if the patient's ANC is 150, then how do you monitor? Because the most important thing that you should know about clozapine is that it has monitoring, okay? Because I've asked students before on rotation, I want to start this patient on clozapine, is that okay? And they said yes. I'm like, do you need to start anything? And they're like, no. And that is completely wrong because there's a REMS program, okay? So if you're going to start somebody on clozapine, you need to understand that there's safety issues associated with it. You have to be very careful with it. So you check an ANC before you start the patient. You can't even enroll the patient in the REMS. I mean, when you enroll the patient in the REMS, they won't even let you start clozapine until the ANC is cleared. And then you start the patient on the medication, titrate the medication up, start to monitor for hypotension, orthostatic hypotension, sedation. And the reason that you titrate clozapine is because it really affects the seizure threshold, okay? So if you were to start a patient at max dose for 300 milligrams of clozapine, especially this patient, she could be at very high risk of having a seizure. So you have to titrate because of the seizures and because of the severe orthostasis. It can also cause some cardiotoxicity, but that's pretty rare, and some GI effects in terms of stasis of the GI system, and that's pretty rare too. Most of the things are drowsiness, sedation, and those are short-term type side effects. And then you continue to monitor the patient, and in terms of laboratory monitoring of serum levels, that is not absolutely necessary. Usually we will get serum levels only if the patient is on an adequate dose and not responding, or if they're having a lot of side effects and they're on a very low dose of the medication. So those are the only two reasons to monitor the patient. We don't just monitor because we need to monitor, but you can if you want to. Does anybody have any questions about clozapine? Okay, so with haloperidol, you would just monitor for extrapyramidal symptoms. We'll get into that a little bit more in the next case. You still monitor for metabolic side effects for any antipsychotic as well, okay? All right, you talk about adherence and efficacy, and those are the other things that you would educate the patient about. Okay. All right, so let's, what time is it? 10:19. Let's take about 5 minutes, and then we'll come back and finish case 3. We'll see if we can get to the additional questions, and if not, then I'll just let you know what the answers to them online. So 5 minutes from now is 10:25. Guys can get up and stretch, or you can ask me anything about psych stuff.
Yes, the PCB.
Yep. Oh, I'm
40, and that's
I traded in my iPad, my old iPad, and they gave me $30.
Oh my god.
It was like the very first generation one. I was gonna trade in my iPad until it broke yesterday, and then like since it wouldn't turn on anymore, it has no value to me. I could have gotten $100 for it.
If I ordered it online though, would have to mail them my laptop. I literally have mine in a car in my box in a box to figure out what I want to do. Like for this laptop, what I want to transfer to the new one. And I'd rather like have a couple of days with both to like figure it out before I give my old one back to them. Because I don't want to buy an external hard drive.
If you, I mean, if I was in Canada, I'd just go to the App Store and buy one, and then take yours back to it.
What I did, I bought this online, and printed in and everything, and then switched everything over, and then sent it back.
I think
it's $2, but it's free. I don't know if I should just go in and get it though, or wait until Sunday Monday, but since it's a brand new one, it's not going to go on sale. It's literally the brand new.
Do you use eBay? I don't even think Apple's on eBay. The only thing that would honestly change is if Apple's on Ebates.
I can't trust myself now.
No, Ebates.
Oh.
Do you use Ebates?
I don't.
Like cashback?
I signed up for like Apple Insider notifications. That's how I got the AirPods on sale.
How much is the new one?
Which one?
The one you're getting?
1,400 for the 256 gigabyte storage.
$30 cashback. I mean, it's only 2%.
And then if I get it like through the Apple Education website or whatever, that's when it was $13.
Okay, we'll get started again. Okay, case number 3. Let's talk about another patient here. DW, does he meet criteria for schizophrenia? Let's talk about some of the symptoms. Okay, so the reason I keep asking about symptoms is, and I don't know if other faculty have probably told you this, like we're not here to diagnose the patient, but we need to make sure that the medications are appropriate for the patient. So if the patient has been misdiagnosed based on the symptoms or the labs or whatever, then you should know that the patient doesn't need to be treated with the medication that would be first line. And so the reason I ask about symptoms is to just make sure that you understand, because on the test it's not going to say the patient has schizophrenia. What are the treatment options? So it's going to give you a couple of different symptoms, and then you're going to have to make a determination of whether or not the patient has schizophrenia or depression or bipolar disorder, whatever the case may be. Okay. Sometimes it's not clear. So what are the symptoms of this patient, group number 7?
Auditory paranoia and delusions.
Yep. Okay, so those are the positive symptoms. And then any other types of symptoms? Group number 15.
I like doing Christmas shopping with it. Because they'll do
Lack of judgment and insight, and then disheveled and unkempt appearance.
Okay, yeah, not taking care of himself. I don't really see negative symptoms, but there are some cognitive symptoms. So yes, those are all the symptoms. And the other thing is that schizophrenia has a chronicity associated with it, so a patient has to be sick for at least 6 months. Okay, so sometimes people come to the hospital and they are psychotic for a week or so, and that doesn't mean that they're diagnosed with schizophrenia and need to be on lifelong treatment. So it's not a chronic condition until it reaches 6 months of symptoms, and then you get put on antipsychotic pretty much for the rest of your life. Especially if you have, flare-ups and things like that. So the patient needs to have symptoms for at least 6 months. So when you visit DW, so he's been on some medication, some chlorpromazine for a few days. It was just switched to olanzapine. Now you see that his tongue is pretty stiff and he has trouble swallowing. What's going on with this patient? Group number 22.
We think it's dystonia.
Okay. All right, and let's see if group number 3. Do you guys agree that it's a dystonic reaction?
We agree.
Okay, so between the two of you guys, what are you guys going to do for this patient now?
We would give an anticholinergic like benztropine or diphenhydramine would also be an option, intramuscular or IV.
Okay. All right. Felix, you guys agree? Your group agrees?
Yeah, we agree as well. So it'd be what they said, an IV, and we follow it up with oral medication.
Okay. So you guys tell me, why do we need to follow up with oral medication? Why can't we just give a dose of IM or IV, reverse it, and then get on with it?
To prevent recurrence?
Yes. Okay, excellent. So we are going to definitely stop the olanzapine, no more of that. And then we're going to give him some IM anticholinergic agent to quickly reverse the symptoms. And it usually is fairly quickly, 15, 20 minutes, maybe a little bit faster than that. And the reason that you do IM or IV is because an acute dystonic reaction can be a medical emergency because it can cause contraction of the airway and patients can stop breathing. And so you do that because patients probably can't swallow either. So you give an injection, and then after the patient has become unstuck or uncontracted, then you give oral medication because the anticholinergic agent intramuscularly or intravenously doesn't last as long as the oral olanzapine in the body. So you need to continue anticholinergic agent until the olanzapine has metabolized out of the body. Even though he only got 1 dose, you just want to make sure and treat him for at least a day, 24 hours. Good. So now that he's gotten some reactions to 2 medications, please recommend something else for this patient. Group number 8.
Try monotherapy with aripiprazole, 10 to 15 milligrams once a day.
Okay. Okay. Good. Let's see. Group number 16. What did you guys choose?
Okay.
Okay.
But of course, we'd still be concerned
avoid the first generations just because the patient, usually dystonic reactions occur with more potent dopaminergic agents. So first generations are very dopaminergic. And so there's a higher risk of extrapyramidal symptoms, one of them being acute dystonic reaction. So I generally avoid first generations for now because there's still some options left in the second generation. So I say aripiprazole is an option, and it has lower risk of metabolic adverse effects. So yes, I would accept that. 10 to 15 is fine. Did anybody else know? And then quetiapine. It could be an option, but he really doesn't have any problems with sleeping or eating. He's had some anticholinergic and sedation problems with chlorpromazine. And then you would have to use higher doses. So if you were going to use quetiapine, those are the considerations. Closer monitoring, and he might be over-sedated, and you have to target 600 to 800 milligrams. So I would say quetiapine might be like a second choice after aripiprazole. Did anybody else choose anything else?
Could you try Risperdal?
Yeah, you could try Risperdal if you start at a lower dose. So one of the things with Risperdal and its counterpart, haliperidone, is once you start getting to higher doses, it becomes a very potent dopamine blocker, and it starts to look more like a first-generation antipsychotic. And so Risperdal is one of the first, it might have been actually the second-generation antipsychotic to come out. It's been around for a long time, and so it looks very similar to a first-generation. And so the reason I didn't want to use that necessarily is because I didn't know what dose the patient would need, and once you get to 5 to 6 milligrams a day, you can be at risk for more extrapyramidal symptoms. So I would say that would be maybe more of a second-line option for me. So yes, as long as it's monitored, that may be after aripiprazole. I'm trying to rank all these things for you. Any other options that you guys stated? Okay, so I would say a couple of other things that you could do is acenapine if the patient is educated on administration. So he's eating well. If he can follow directions, you can put him on that. Brexpiprazole, in my mind, is very similar to aripiprazole. If you actually look at the chemical structure, they're very similar. So if you put him on aripiprazole, it's been around for longer, so it's a little bit cheaper. I'm obviously not going to ask you about cost of medications, but aripiprazole or brexpiprazole are like sister medications, sister or brother medications or whatever. Let's see. Maybe so lorazepam, since eating is not really a problem for this guy, you can put him on that as long as you educate him on that. And then I was leaning towards ziprasidone actually. And so the reason I lean towards ziprasidone is because he is eating well. If he becomes agitated, we can give him short-acting ziprasidone. So we don't have to add on some other antipsychotic and lead to polypharmacy. So even though it's going to be used just acutely, we don't ever use rapid-acting antipsychotics long-term. They only should be used for very limited short periods of time to treat acute agitation. So we could do like ziprasidone, PRN ziprasidone IM, and then just educate him on eating with each dose, and it also has a low risk of metabolic adverse effects. So those are just general things. And this is a patient that's only been on, I think, a couple of medications. He's a little bit of a newer phase patient with schizophrenia. Okay, so now that we've stuck with some of the second-generation antipsychotics, and if you're not clear on why I chose that option, please let me know so I can clarify for you. How would you monitor just the second-generation agents in general? Group number 23. Question was, what do you mean in general? You just tell me what monitoring parameters or for the agent that you chose. Yeah, so.
So if we were going to do Suprazidone, we would have to make sure that they're eating that 500-calorie meal, and
Okay.
we need to monitor their QTC.
Okay.
But if we were going to do something like typing, we need to monitor, like you said, to make sure they don't need that higher dose.
Okay.
And watch for sedation and orthostasis.
Okay.
And if we were doing Abilify,
Okay.
Acasthenia.
Okay. Akathisia. Akathisia is just another word for inner feeling of restlessness. It's usually manifested as patients like moving back to back, side to side on their foot, or just pacing up and down. So inner agitation. Not painful at all, but can be very distressful for the patient. Okay. Let's see, group number, that's question number 4. Okay, group number 2. Anything else to add for safety and efficacy monitoring?
We pretty much agree with what the other group said. I guess there's still kind of a risk for the extra pyramidal symptoms, so we still have to watch out for the all of those symptoms too.
Okay. And there's one other group of side effects that you're missing in terms of monitoring, which has not been stated yet, which we have talked about before. What else? This applies to all antipsychotics. They have a risk of extrapyramidal symptoms. You can get extrapyramidal symptoms with any of them, even though it's more likely with higher potency agents. And what else can happen with all antipsychotics? What other side effects? That's why I say in general.
Oh, so the metabolic ones too?
Yes, absolutely. Okay. So for all antipsychotics, you always have to monitor the metabolic panel, and we kind of discussed what was on that panel. So no matter what you're on, you should monitor for that. First generations are less likely to cause metabolic disturbances, but there are studies showing that they do cause some disturbances, just less likely. Okay, good. And then let's see, DW is discharged from the hospital because he got better, and he's been following up in clinic, and then he sees you, maybe you're doing medication management for the provider that you're working with, and he says he's not aware of it, but his family says he's got some tongue rolling and lip quivering. So what exactly is going on now? Group number 9.
Tardive dyskinesia seems to be occurring and is potentially irreversible if not addressed early, so we would want to dose reduce or switch to another antipsychotic less potent D2 blockade such as quetiapine.
All right. Let's see if group 6 has anything to add.
We said almost exactly that, like,
Okay. All right, so I completely, and that's what I wrote down too. I mean, so I do all these cases before the class too, and I wrote that down as well. So it is tardive dyskinesia, and the reason that it is that is because usually it starts occurring in the face first, and it occurs several months later. And lip quivering, kind of tongue flicking, lip smacking, those are some of the first signs and symptoms of tardive dyskinesia. And if you didn't watch those videos on movement type side effects, sometimes it's really hard for people to verbally, or for me to verbally describe to you what the difference between all of these extrapyramidal symptoms is. But once you see it, you can kind of understand what the difference is. So tardive dyskinesia is tardive. It happens usually later on. And it is absolutely correct that it can be reversible if you keep the patient on the medication. So it's time to reconsider the therapy for the patient. especially something that's a little bit less dopaminergic. So if anybody has any questions about the other extrapyramidal symptoms, like Parkinsonian symptoms or akathisia, please let me know so I can clarify for you, because this patient didn't have any of those other things. So let's talk about question number 6. The psychiatrist decides to use clozapine, and the patient agrees. So good. And now there's a consult to the pharmacist-managed clozapine clinic, which does exist across the country. So please describe how you would transition the patient to clozapine and what your treatment plan would be. Group number 24.
So we said we're going to taper the patient off of their current antipsychotic at the same time of initiating the clozaril. We'll initiate the clozapine at 12.5 milligrams once or twice daily, and then we'll increase it as tolerated in increments of 25 to 50 milligrams to a target dose of 300 to 450 milligrams daily, and that will be in divided doses, and we want to do that by the end of 2 weeks from initiation of the clozapine.
Okay. Let's see, group number 1. Take it back to you guys. So we've been provided a dosing strategy. What else do you need to do about clozapine in terms of initiating the medication?
The ANC should be monitored weekly for 6 months, every 2 weeks for 6 months after, and then after 12 months monthly, and the ANC should be greater than 1,500.
Okay. All right. Yes, so I would agree with tapering off the ziprasidone and I would probably taper off fairly quickly. And as once you get to the clozapine higher levels in about a week or 2, the patient should probably be off the ziprasidone. Because he is having a little bit of tardive dyskinesia, 1 or 2 weeks is not really going to make a difference in terms of making it irreversible or not irreversible. So you're already tapering off anyway. So you can do it cross-taper and titrate over the course of about 1 week or so. But before you start the clozapine, definitely get an ANC, make sure everything's squared away, and then let the patient know he's going to have to be monitored at least once a week for the first 6 months. And then it can reduce, because the risk of agranulocytosis goes down over time. So that was it. And then the patient, I think, is adherent, but he should be educated to not miss more than 72 hours worth of medication, or else he's going to have to restart the titration once again. And then he should be informed about some of the safety things that we already previously talked about, but since we already talked about them, I'll state them over and over again. So it's just important to monitor, all these different safety and efficacy things. Does anybody have any questions about that case? All right. Or anything in general? All right, so we're gonna, since we have about 10 or 15 minutes left of class, I'm just gonna go through the additional concept questions, and these are here just because I wanted to make sure that you guys hit these when you study for the exam. And so you didn't have to answer these before, but I'm just going to ask the class, and anybody can answer, so there's no assigned group to answer these questions. So which antipsychotics would you consider avoiding in patients with metabolic syndrome? Who has an answer?
Second generation psychotics.
Okay. With metabolic, so so in general, second generation antipsychotics, yes. Are there any specific ones you would want to avoid? Because sometimes, some of them have lower risk of metabolic symptoms like Abilify or aripiprazole and ziprasidone. So which ones have the highest risk of metabolic?
Olanzapine?
Yes. Olanzapine. What else?
Clozapine?
Yep. And then one more. This is like third in line. So clozapine and olanzapine are considered the biggest, we call them weight gainers or just metabolic disturbance curves out of all the antipsychotics. But quetiapine is also up there in terms of causing weight gain and blood glucose disturbances and things like that. So if you have a patient with metabolic syndrome, obesity, hypertension, and all that type of stuff, you want to try to avoid these if possible. Preferred ones, you would probably stick with things like aripiprazole, brexpiprazole, ziprasidone, lorazepam, and in general, the first generation antipsychotics are going to be a little bit less of an effect on the metabolic parameters. Okay, and so if you look at that chart in the, you look at that table in the book that has all the pluses and minus signs. I don't expect you to obviously memorize that. That would be a silly thing to do. But what you want to take away from that table is what things cause more problems and what things are less likely to cause problems. Because when I ask you, this patient has metabolic syndrome, which agent should you choose? Then you should just think about, aripiprazole, brexpiprazole, look for that answer among the agent choices. So what is the difference between high and low potency first generation antipsychotics? Something I talked about in the slides, and I don't know if it was in the book.
The side effects are different. For high potency, they have movement disorders, and for low potency, it's anticholinergic, antihistaminic, and antiadrenergic.
Absolutely. Okay. So one of the things to think about is if you have a patient that has, and this is where we use chlorpromazine. When we have a patient that's extremely agitated, not sleeping, has slept 0 hours in the past 3 days, usually we go with a very strong agent like chlorpromazine. This is what, when you're watching movies back in the old, I don't know if you watch old movies back in the old days with mental health stuff, people drooling on themselves, that's definitely not how we treat patients now. We do not try to over-sedate them at all. But most of those patients were on chlorpromazine because it just knocked them out. And so we actually reserve chlorpromazine for patients that have tried and failed a lot of different antipsychotics and just are kind of off the chain and not really responding to anything and still potentially violent, impulsive, and not sleeping. So they also have a lot more side effects, anticholinergic, antihistaminic, and antiadrenergic, as was stated. Okay. What medications are used to treat Parkinsonian symptoms? We kind of discussed this already, anticholinergic agents. If the patient only has like a pill-rolling tremor, you could probably stick with propranolol. And if none of the anticholinergic agents work, then you might try amantadine, but there's more issues associated with amantadine, like side effects. With akathisia, generally you want to use propranolol or benzos, and this comes from the book and the slides. Dystonic reactions, definitely anticholinergic agents. We already discussed how to treat that, the strategies for that. And then tardive dyskinesia, what can we use to reverse that? Let's say somebody shows up to the clinic and they've had 40 years of schizophrenia. What are the agents used to treat tardive dyskinesia?
Valbenazine and deutetrabenazine.
Yeah, you got it. So valbenazine and deutetrabenazine, which are VMAT2 inhibitors. And the patient will have to be on those pretty much lifelong because tardive dyskinesia is irreversible. I will tell you that we hardly ever use those because it's about $5,000 a month, which the insurance will not cover. But obviously that's not a good example. So how does clozapine monitor? What antipsychotics have special programs? We already talked about clozapine monitoring. So I would just refer you to the REMS handout that I also posted. Besides clozapine, what else has a REMS program? Yeah, so olanzapine long-acting injections, Zyprexa, Relprevv. And so what that means is you have to enroll the patient, the healthcare facility, the provider, the pharmacist, everybody has to be enrolled. And the patient has to consent to taking this medication. That's usually where the barrier occurs. Because many years ago, I enrolled patients to take Zyprexa, Relprevv, and I found out that even if I found a provider in the community that would continue the injection, most of the patients were taken off of it because it was very hard for them to just sit in an office for 3 hours and nobody was going to do that. You have to have also access to emergency services. So unless you have an institutionalized patient, I don't really think this is a reasonable option for most outpatients. Okay, and the reason those are important, if you ever get a prescription for that, you should know obviously not to fill it until you enroll the patient in the REMS program or to dispense it. Which antipsychotics are affected by food? You've got lorazepam, ziprasidone, acetylcholine. Okay. Which antipsychotics cause the most orthostasis? So this comes from table 67.6. So we talked about some of them. Can anybody list got about 4 of them listed.
Chlorpromazine, clozapine, and thyroidazine.
Yep. Yes, chlorpromazine, thyroidazine, because those are both low potency first generation agents. Clozapine, high rate of orthostasis, and iloperidone as well. So you have to titrate slowly on iloperidone because of the orthostasis. Okay. And so in terms of sedation, it's very similar. So if you think about just grouping agents together, that can sometimes help. So a lot of sedation happens with the first generation low potency agents, chlorpromazine and thyroidazine, and then clozapine has a lot of sedation as well, and then quetiapine. Anticholinergic ones, low potency first generation agents, clozapine. In terms of EPS, in general, it's the first generation agents, and with metabolic type side effects, in general, it's second generation agents. But please know that the difference between the individual agents within that class are going to vary. And so the reason that all the agents in the second generation class are so different from each other, and they're not interchangeable really at all, except for paliperidone and risperidone, is because they affect so many other neurotransmitters, and so they're really different from each other. They have different personalities from each other. There's no way that you can just go ahead and switch patients from olanzapine to risperidone in an equivalent dose. That doesn't exist. Who are patients for long-acting injections? These are generally going to be patients that are open and willing to taking a long-acting injection, and patients that forget to take their medications or non-adherent for reasons where the patient understands the benefit of taking medication. So if you have a patient that's like, I don't think I'm sick, I'm not going to take, I don't think I'm sick, so I'm not going to take any medication. If you force that patient to take a long-acting injection, they're never going to show up for their next appointment to take another injection. So that really isn't a patient for a long-acting, because you really need somebody who understands that they need to take their medications. But there's a lot of psychosocial factors, and that has to do with hospitalization. Some people just think, oh, let's just give everybody a long-acting and try to keep them out of the hospital for 30 days, but that's really not a good strategy to ignore the fact that patients are not adherent for many reasons. Okay, so what is MMS and how is it managed? So aside from all the different side effects we talked about, there's also neuroleptic malignant syndrome. What is that? Any thoughts? Why it happens, what needs to happen if the patient has it? You can listen to the sawing in the next door. Okay, so it's basically due to any antipsychotic agent. So anything that blocks dopamine can cause neuroleptic malignant syndrome. And basically, it's a triad of symptoms, including autonomic instability, muscle rigidity and stiffness, and altered mental status. So usually patients have to show up with some three, obviously all three of those symptoms, but they can vary in different degrees. So the treatment is to stop all the antipsychotics and make sure that the patient receives supportive care, because there is no real antidote for neuroleptic malignant syndrome, and it can occur at any time the patient is on antipsychotics. So it doesn't have to occur with the first dose. It can occur after a patient's used antipsychotic for 10 years. So you just have to be aware of that. And then the last question, which medications might be used in a strategy to treat or target schizophrenia with acute agitation? You can use intramuscular antipsychotics that are rapid acting, or you can use benzos. So usually lorazepam or clonazepam for acute agitation, or you can use a combination of those things. Okay? Does anybody have any questions, comments, concerns? concerns for me? Okay, so class is over. So have a good Thanksgiving break, and I will see you guys back on the Monday after Thanksgiving.